Dear docs, I welcome you all to the 5 Minutes Guideline series. Today we will be discussing about the epilepsy in pregnancy, which is a Green Top Guideline 68. It came in 2016. So let's see the layout of this guideline. The layout will be the diagnosis, medication, pre-pregnancy management, antepartum management, intrapartum management, postpartum and contraception. So the diagnosis on the differential diagnosis. The guideline says that the epilepsy or the epileptiform seizure, they should always be diagnosed by an expert in epilepsy. Usually it should be a neurologist. The women who are not considered to have a high risk of unprovoked seizures can be managed as a low risk women in the pregnancy. And the women who develop the seizures in the second half of the pregnancy, where there cannot be a clear diagnosis attributed to the epilepsy, immediate treatment should be started for the eclampsia until a definitive diagnosis is made. Always remember the cardiac, metabolic, intracranial condition as well as the neuropsychiatric condition as a non-epileptic attack disorder. They should also be kept in mind. Then comes the anti-epileptic medications, which are two types. Either they are enzyme-inducing or they are non-enzyme-inducing. Guideline says the carbamazepine, phenytoin, phenobarbital, primetone, and topiramate, rufinamide, and eslicarbazepine. Non-enzyme-inducing drugs include benzodiazepine, ethosuximide, gabapentin, lacosamide, levetiracetam, sodium valproate. These are all the non-enzyme-inducing medications. The pre-pregnancy counseling and the management. Women with epilepsy should be reassured that the risk of the congenital malformation is low if they are not exposed to the anti-epileptic drugs in the periconceptional period. And the effect of the risk to the abnormalities of the baby depends upon the type, number, and the dose of the medications. The major congenital abnormalities which are associated with these medications, they are neural tube defects, congenital heart defects, urinary tract, skeletal abnormalities, as well as the cleft palate. Remember, sodium valproate is specifically associated with neural tube defects, facial clefts, and hypospadias. Phenobarbital and phenytoin, they can give rise to cardiac malformation. Phenytoin and carbamazepine both can give rise to the cleft palate in the fetus. You can get the single best answers questions in the exam. And what to give them 5 milligrams per day of the folic acid in the periconceptional time as well as during the conception, specifically till the end of the first trimester, to reduce the incidence of the major congenital abnormalities. Lowest dose and the minimal medication should be given. Always avoid the valproate. Valproate should not be given in the pregnancy. Remember this, you can get the question about it. Then comes the antepartum management. What is the recommended model? Regular planned antenatal care as a multidisciplinary team with a designated epileptic care team should be the plan. Women with epilepsy, if they are on the medication, they become unexpectedly pregnant. Then they should discuss the therapy with an epileptic specialist on an urgent basis. Never recommend to stop or change the medication abruptly without an informed discussion. All the pregnant women who are epileptic, they should be provided with the information about the UK epilepsy and the pregnancy register, and they should be invited to register for that. Anomaly scan 18 to 20 plus 6 weeks for the cardiac as well as neural tube defects. Routine monitoring of the serum level of the medications during the pregnancy is not recommended, although the individual circumstances may be taken into account. The regular assessment for the risk factors such as sleep deprivation, stress, they should be avoided, and adherence to the medications and is very important. So then comes the admission. If admission is required antenatally, then the women with epilepsy, they should be accommodated in an environment where it allows for the continuous observation by a carer or a partner or a nursing staff. Serial growth scan for detecting the small for gestational age fetuses reassure that most of the women will have an uncomplicated labor in the delivery. The diagnosis of epilepsy per se is not an indication for planned cesarean section or induction of labor. Then comes the intrapartum management. Women with epilepsy, they should be counseled. The risk of the seizures in the labor is low. Give them adequate analgesia, avoid insomnia, stress, and dehydration. Long-acting benzodiazepines such as clobazam can be considered if there is a very high risk of seizures in the peripartum period. Medication should be continued during the labor. If this cannot be tolerated orally, a parenteral alternative should always be administered. Then comes the optimum management of the epileptic seizures in the labor. Every obstetrical unit should have a written protocol or the guidelines. Seizures in the labor, they should be terminated as soon as possible to avoid the maternal and the fetal hypoxia and the fetal acidosis. Benzodiazepines are the drug of choice, remember it, but avoid the pethidine. Diamorphine can also be used. Continuous electronic fetal heart rate monitoring is required in the women who are at the high risk of the seizures in the labor and following an intrapartum seizures. The woman with epilepsy at the risk of the peripartum seizures, the delivery should be in a consultant-led care with facilities for one-to-one midwifery care with maternal and the neonatal resuscitation. Water birth decision should be made on an individual basis, and the women who are not taking anti-epileptic medications and who have been seizure-free for a significant period, they may be offered a water birth after discussing with their epileptic specialist. You can get an EMQ regarding this type of the scenario. Then comes the postpartum management. The overall chances of the seizures during the immediate period after the delivery is low. It is relatively higher than during the pregnancy. So women with epilepsy should be advised to continue their medication postnatally. Make sure that the triggers of the seizures should be avoided or minimized. Screening for the depression and the counseling is very important. If the anti-epileptic medication dose was increased in the pregnancy, it should be reviewed within 10 days of the delivery to avoid the postpartum toxicity. This is very important, the 10 days. Neonate should be monitored for adverse effects which are associated with these medications in utero. Encouraged to breastfeed. Adverse cognitive outcome is not increased in the children who are exposed to these medications through the breast milk. Then comes the contraception. Women with epilepsy, they should avoid unplanned pregnancies, very important. Copper intrauterine devices, Mirena and the depomederoxyprogesterone acetate, they are reliable method. They are not affected by the enzyme-inducing medications. The contraception can be according to the either enzyme-inducing agent or the non-enzyme-inducing medications. If the woman is taking the enzyme-inducing agent, then the hormonal contraception should be avoided. And emergency contraception is the IUD only, which is an intrauterine device. If the woman is taking non-enzyme-inducing anti-epileptic medication, then she can use all methods of the contraception. Then comes a summary. As you know, in each guideline, we do the summary with important points. So, incidence of the epilepsy during the pregnancy is 0.5 to 1% according to the guideline. Type of the seizures include tonic, clonic, absent seizures, focal seizures, juvenile myoclonic seizures. And incorrect diagnosis exposes the mother and the unborn child to unnecessary and potentially harmful drugs. Treatment in addition to the psychosocial burdens such as inappropriate loss of the driving privileges or employment restriction. If there is any doubt whether the seizure is secondary to epilepsy or eclampsia, magnesium sulfate, which is the drug of choice for the treatment of eclamptic seizure, should be administered immediately until a definitive diagnosis is made. Then the medication you should know by heart. Contraception is very important. Counseling about the neonatal care. These are the important points from the exam point of view. So thank you for the watching. If you like our video, please comment, share with your friends, with your colleague, and subscribe to our channel, which is RoyalDocline.